Good evening, everybody. Dr. Shupade, can you hear me? Hello?
Your volume is a bit low.
Okay, I'll try and fix that. Is this any better?
That's much better.
Okay. So I'll just start sharing my screen, and I've made yourself and Dr. Shupade co-hosts so that you can let people into the waiting room while I speak for maybe half an hour. I've left a link to the YouTube channel in the chat box as well for people who are unable to get in because of numbers, or people who would rather just follow us on YouTube. We did have a comment from yesterday from Dr. Niebo saying that it would be nice for us to pick up on the questions typed into the chat boxes on the YouTube page. And I would want to implore Dr. Shupade to do that for us for today. When we get to the question and answer session, he can just either read them out or copy them into the chat box here so that we pick up on them. The only other thing is to say welcome again to everyone and thank you for following us. I have some cases that were sent in through Dr. Shupade earlier, x-rays and a brief description. I am assuming they're all for the same patient. I didn't look at them that much closely, but I've put them up in a little PowerPoint, which we can talk through later on. If there's any other person who wants to send in a case, if you email it, I may be able to pick up on the cases during Dr. Adedapo's part of the talk and be able to get that up as well so that we would have a pretty lively discussion at the end of the day. Having said all that, Dr. Shupade, may I leave the waiting room to you so that I can put up my slides and start talking?
Yeah, please do. Please
Thank
do.
you. All done. So I'll find my slides now. That's quite strange. Where are they? Okay. Okay. That's all right. Good. So I'm giving a talk on skeletal dysplasia, and it's an interesting topic, but fairly obscure for many of us, myself included. I do not presume to be an expert in any of the things I'm going to say today. Certainly not in the genetics or in the medical aspects of it, and certainly not in the spine bits. But the learning points for the day are for us to recognize common dysplasias, understand the basics of genetic principles, because we do have to talk through these things to our patients, and to have something of a stepwise management for planning, or stepwise planning for management, and to always remember that multidisciplinary care is very crucial. Now, by way of an introduction, just a bit on bone formation. Endochondral bone formation essentially is when you start off with a cartilage model, which is invaded at either side by specialized cells to form both the primary and secondary ossification centers. And these are separated initially from the shaft portion by epiphysis, and eventually towards skeletal maturity, everything unites to form an adult bone. The main thing is that the physis is responsible for that growth in length rather than appositional. And we'll see later that specific problems that affect this sort of bone formation would result in short stature, not necessarily affecting the width of the bones. Intramembranous ossification, on the other hand, yes, by the endochondral is what we would find in a lot of long bones, tubular bones. Intramembranous is what we would find in skull bones. And this essentially, you have mesenchyme differentiating into osteoblasts without a primary cartilaginous model. And then ossification occurs, and that becomes mineralized and becomes bone. So, bare basics. What are osteochondroplasias? They're just disorders of cartilage and bone development. From the word dis, which is bad, and the placent part of it, which is just poor formation. So essentially situations where you have poor formation of bone or cartilage resulting in sometimes quite obvious abnormalities that can be seen, sometimes dangerous, sometimes not necessarily life-threatening. The important thing is when you're thinking of a kid having osteochondral dysplasias, you need to be sure that you're looking at the child not in isolation, but relative to the parents. And is the child just constitutionally like this because that's how all of them are in their family, not necessarily that the child is smaller than what is expected for that particular family, that particular race, and so forth. The other thing to consider is whether you think you have a disproportionate problem or a proportionate problem. By way of growth and proportion, these are Caucasian values, by the way, but at different ages, there's a rough ratio of upper limb, upper segments to lower segment ratio that you should find. In Caucasians, by skeletal maturity, you expect that ratio to be about 0.95. And in Blacks, you expect that ratio to be about 0.85. Now, these are just rough guides, like I said. Again, you also want to find out whether you think the person you're looking at has a global discrepancy or whether they're just some particular segments of their limbs that are short. So for instance, rhizomelic shortening would be when the proximal parts of the limbs are short. Acromelic would be when it's more of a problem with the hands. And mesomelic would be when it's the mid portion of the limb that is affected. Fasces are also important because such things as frontal bossing is almost characteristic of achondroplasia. And the osteogenesis imperfecta patients do have a kind of triangular shaped face, which you can easily see in the very severely affected children. Anatomically, we can think of, and this is probably one of the more useful clinical methods of classifying skeletal dysplasias, are these problems epiphyseal, in which case you would have joint problems occurring. Do they affect the spine? In which case you would have things like scoliosis or kyphosis or a mixture. And you would also have the, what's the word now? The spondylo as part of whatever description you are giving for the deformities. And are they affecting the metaphysis, in which case you would have a lot of angular deformities resulting and you would have short stature. In terms of the genetics, you want to know essentially whether these problems are autosomal dominant, in which case you only need one copy of the gene to get the disease, something like achondroplasia, for instance. Or are they recessive? This is important in counseling your patients in terms of what the chances are for them having another child with the same problem, and in terms of counseling the parents about the chances of their own affected children transmitting this same skeletal problems forward. So I will leave the science of how we inherit things, but just to say that it's important to look not just at the family tree from the mother's side, but also to try to get a bit of picture of what is happening on the father's side as well, knowing that most times mothers will bring the patients to them to the clinic. Because sometimes it might be one grandfather who had, joint problems, and that might be the clue to your diagnosis and all that. Um, by way of gene structure as well, it's just important to note that the genes generally start transcription from the 5' ends, and the transcription ends are the 3' ends. And this essentially tells the body what sort of amino acid to produce at the end of the day. And when you do have substitutions eventually occurring or mutations, you would generate differences in the amino acid product of that particular gene, which may or may not be transmissible, depending on where that substitution has occurred. So we'll talk a little bit about single nucleotide polymorphisms, and then we'll move on to the bits on actual problems that we would see. Essentially, you can have different types of mutations, and some mutations don't necessarily lead to a problem. Some mutations will lead to an amino acid that's different from the one that normally occurs, and some just essentially stop genetic transcription at that level. There are also other ways of classifying the so-called constitutional diseases of bone, and this is a classification that it's not necessarily useful clinically, but just for us to see, a way of thinking about these things in terms of trying to put them into different areas. I'm not going to go into a lot of great detail here as well, because I want to try and focus more on specific things that we'll see with specific entities that we should be able to recognize. Just to say that, for instance, things like achondroplasia and osteogenesis imperfecta are all classified under osteochondral dysplasias, which is what we're talking about today. But we also have other interesting bone abnormalities, which we would speak to because some of them are syndromic and we shouldn't miss them. Yeah, so specific problems. Achondroplasia is the commonest form of dwarfism, and it's the one you're most likely to see. It's usually autosomal dominant in occurrence, and very rarely it's due to mosaicism. Mosaicism is when you have people who have copies of the normal gene and copies of the abnormal gene in the same individual in their cells. In such people, they tend to have slightly milder forms of whatever deformity it is that's resulted from the abnormal genes they've inherited. For exam purposes, it's important to note that it's a mutation of the fibroblast growth factor receptor 3 gene, and that it's a glycine to arginine substitution resulting from this on the short arm of chromosome 4, which eventually leads to slowed endochondral ossification. So the bones are short, even though a positional growth gives them normal weights. Essentially, you have people who have short stature, usually worse in the upper limbs, and we'll talk a bit about the importance of this later on in management. The faces, they have marked frontal bossing, they have broad starfish type hands, and they may have elbow contractures and radial head dislocations. And because the fibula tends to just be longer than the tibia, they tend to have fairly distressingly obvious bowing of the lower limbs. Now, on x-rays, we would see probably the most characteristic feature is in the pelvis, which I'll put up, and you find that the ileum is square shaped, the acetabulum is flat. The obturator foramina are small, not so much in this particular person as well. And then you can see the amount of bowing that this patient has got even at a fairly young age. The fibular lengths here are roughly the same as the tibial lengths, and they will eventually overgrow, okay, which would worsen the bowing even further. Diagnosis prenatally, you can't suspect this when you have babies who have a femur length that is shorter than what the age of the pregnancy is supposed to be. And in the newborns, by visual inspection, you would be able to pick up some of these children. In the older child as well, same thing. Now, there are lethal forms of dwarfisms which we would not discuss, such as the thanatophoric ones, because these ones would not even make it enough to actually get to you with deformities in the first instance. What are the orthopedic problems they can have? They can have things like Chiari malformations, and they can have significant compressions around the area of the foramen magnum. So it's important to look out for hyperreflexia in these children, because that would prompt you to do an MRI and be sure that you don't have a child who's just going to essentially die in their sleep, or have very severe neurologic deficits. They could have they could have thoracolumbar kyphosis as well. Some of this is due to poor tone, which may improve with time. They could also have a lot of angular deformities, which is what would usually come to the orthopedic surgeon. And what they tend to have is usually varus. How do we manage these problems? One, we've already spoken about the fact that they tend to have a fibular overgrowth relative to a tibial length that's quite short. So a fibular epiphysiodesis, you may need several osteotomies for them, and you may need to lengthen their upper limbs at the humerus, because sometimes their upper limbs are so short that they actually can't reach behind to toilet. And you may also need to lengthen their femurs and tibias, either sequentially, or some people do it like femur tibia on opposite sides of the body at the same time. Now, there are some interesting psychological aspects to managing children with achondroplasia, because they do tend to have societies, particularly in established, climes and so forth. And by offering them lengthening, or by taking them through lengthening, you cannot get them to a normal adult height for that population. But again, by lengthening them, you've taken them out of the strict criteria for achondroplasia. So you may then have somebody who's no longer accepted by his fellow achondroplastics and who is not normal height. So those are important things to talk through with them as well. Hypochondroplasias are less common. They're very like achondroplasia, except that the eventual height of these patients is not as short. And overall, the features you would see are just generally not as obvious or not as severe. And in summary, they may be quite easy to miss, particularly if you're seeing that patient in the setting of a family member who's also roughly, proportionate and about the same height himself. Orthopedic problems are similar, and perhaps there's some role for growth hormone in this particular group as well. Metaphyseal chondrodysplasia, I'll spend a little bit of time on, because I think we do see quite a bit of this in the environment, where a lot of it gets lumped together as query blounce. Now, this is essentially due to failure of mineralization, and it leads to features that look a bit like rickets. There's the Janssen type, which is more severe, and you'll find these problems at birth, and they're due to parathyroid hormone or parathyroid hormone-related protein mutations, which is found on chromosome 3. Radiographically, they're very, very similar to rickets, but they do tend to have a lot more severe metabolic abnormalities. The Schmidt type is the one I think we do see in our environment. We find this in children who are roughly about the age of 3 to 5, which is about the same age as you would start seeing them coming with blounce. And they predominantly have problems from a mutation of type 10 collagen, which is on chromosome 6 for those who are interested and for exam purposes. Again, the predominant feature is problems around the metaphyseal area. They have a lot of coxa vara, these particular ones. And in addition to seeing a child with an angular deformity, if you do take an x-ray from the pelvis down to the feet, you would see that it's the bones of the lower limbs are bent in addition to whatever, obvious problems you have at the level of the knee joints themselves. So the crucial thing for this is you mustn't think it is blounce because it would look like blounce. And if you just stick in your 8 plates in this kind of children, you don't correct the deformity. In fact, sometimes the deformity is not at the knee joint. If you then do a proper alignment view from hip down, you find that there's actually more of a bend coming from the proximal femurs rather than from the knee joint itself. Oh dear, my screen's frozen, so I'll just stop share and reshare again. That usually solves the problem. Sorry about that. Okay. Yes. So orthopedic considerations, we correct the deformities as they require, and this again, like the achondroplasias, tends to require both hemiepiphysiodesis and osteotomies of the femurs and tibias. Now for X-ray features, if we look at this particular X-rays, you can see that the first two are compared with something that looks a bit more normal, but this first two X-rays, these first two films show that the bones of the femur and tibia themselves are not straight. And you can see quite a bit of metaphyseal widening and a bit of splaying as well on both sides. So there could be some degree of physeal widening as well, but not much in the Schmidt type, unlike the Janssen type. Now, I'll mention multiple epiphyseal dysplasias as well because they're important differentials for things like PETHs and things like GDH. The classic thing with MED is the epiphyses are small and they are slow to grow, and they just don't catch up with the rest of the bony development of that particular child. So you find a child who looks like, say, age 9, and the epiphyses are not looking like age 9 at all for that person. Here, for instance, you can see that this child looks pretty near, nearing skeletal maturity. It doesn't look like in age 4 or 3, for instance. But the epiphyses are the size of what you would expect in, say, a 1.5 or 2-year-old. If you look at the knee joints as well, you can see that the epiphyses are just misshapen. They just don't look right. But the rest of the bones that we can see, diaphysis, metaphysis, are normal. So moving swiftly on, we'll go on to some rarer things that we just mentioned quite briefly because examiners like them and we should know them at least for MCQ purposes. Osteopetrosis is also called marble bone disease. Melorhostosis is interesting because it looks like you've dripped candle wax down the side of a candle, and the bones actually do look like that. Caffey's disease is infantile cortical hypostosis. I'll talk a little bit about that because it's probably not as rare as we think it is. Now, this is a self-limiting problem. Essentially, the bones just form periosteum, almost like you have an osteomyelitis, except that it can be quite painful. It tends to start off in the mandible, and some of the earlier signs might be a child who's just refusing to eat because he's too sore. The treatment really is just watchful waiting, some bits of anti-inflammatory medication, but they may require deformity correction. So this is a picture of that. So it's something to think about when you have query osteomyelitis without necessarily having osteomyelitic features. And you want to see whether you have similar problems in other bones as well before you start whacking the child with antibiotics. Mucopolysaccharidosis are an important differential for things like achondroplasia, and they do result from accumulation of glycosaminoglycans. For example, we have to remember heparan, keratan, or dermatan sulfate as the main types, or as the three types of glycosaminoglycans. Essentially, they're enzyme deficiencies which tend to lead to different types of deposition of these substances in the nerves and in the soft tissues. I'll talk a little bit about hurlers because it's one of the commoner ones as well, and just out of interest. So this is autosomal recessive. Recessive means that you need to have a copy of the abnormal gene from the father and a copy of the abnormal gene from the child from the mom for the, what's the word? For the child to have that. So you need two copies of the abnormal gene. Now, it's a deficiency of a specific enzyme, and essentially they have quite interestingly coarse features. So you have a flat affect, a face that just, it's hard to describe some of these things, honestly. But they do have what is described as coarse features, maybe similar to what you would find with people who have like pituitary enlargements from tumors and all of that. They also have something similar. They could have some learning disability, they could have kyphosis and so forth. But the thing I want to bring out is how commonly they have carpal tunnel syndrome. And this leads to disabling loss of function for them. And it's something to keep in mind if one ever has to look after them. Other problems that may come to the orthopedic surgeon include things like Marfan's. Marfan's, you usually can't miss them. You see somebody who is just extremely tall, and they have long limbs, thin limbs, a lot of ligament laxity and myopia. Now, it's important to always send these sort of children or persons for a cardiac review because they can have valvular prolapse of the mitral valve and aortic dilatation, which can prove fatal. And many times they need to be on vasodilators for life, really, and to be watched quite carefully because of the risk of heart failure and so forth. Now, for the orthopedic problems, they could have a lot of issues with the ligament laxity. So things like flat feet, scoliosis are problems. Interestingly, their flat feet can be quite difficult to correct, and I think one should just try and brace them for as long as it's possible, and then once they're old enough, fuse them, because doing the conventional flat foot surgeries for children really doesn't work. They essentially just recur again. So Beal syndrome is quite like Marfan's, not very common. I've seen just one, but it's interesting because it's a differential diagnosis for people who do have very severe joint contractures. They just have contractures in all the joints, almost like they have webs over the joints. In addition to this, they have quite a lot of bone fragility as well and are at risk of having multiple fractures. Treatment for them would be to brace them and fuse them as required, and then serial casting for their contractures is useful. Nail patellar syndrome is useful to be able to recognize. The classic thing you would see is a child who has a patella that's very small or non-existent, and they tend to have a lot of recurrent patellar dislocation. So when evaluating for recurrent patellar dislocation in children, it's also worth taking an eye at the patella size to see whether you think that patella is abnormal and if you think there is anything constitutionally wrong with that. In addition to the patella, they also have quite dystrophic nails, hence the name nail patella syndrome, and you can't miss that. But for them as well, the medical problem they could have is, kidney failure. So it's really worth evaluating some of these seemingly simple recurrent patellar dislocations properly, because you don't want to miss the chance to prevent somebody from having kidney failure in middle age. Treatment is really non-specific and you just manage the patella as required. Larsen syndrome is hard to miss because the children who have very severe, extreme joint dislocations, and these joint dislocations are pretty much everywhere. So you have a baby born with dislocated hips, dislocated knees, elbows, everything dislocates in them, and they could have a lot of joint contractures as well. It's also crucial to look in these for signs of cord compression. And the treatment really is just serial casting. So you just treat the hips the way you treat a normal DDH, except that you know that this is a much longer road, so to speak. And you may have to correct the spinal deformities as well. And you may have to fuse the feet somewhere along the line, just to try and keep them braceable. APATS is so-called one of several acrocephalosyndactyly syndromes, meaning that they have problems involving the hands, involving the head, and they do have that. So it's autosomal dominant, and sometimes it may be a spontaneous mutation. We had one such girl like that, perfectly ordinary mom, and then the girl has APATS. The main thing with them is that they have premature closure of their sutures, the sutures in the skull. And because of this fusion, the brain doesn't develop as quickly or as well as it should. And then they start having problems with intelligence because of restricted brain development. So they're born with essentially normal intelligence. In terms of distinguishing features, they have a delta phalanx in the thumb, which is proximal phalanx of the thumb is not rectangular or square like it should be. It's actually like a triangle. And then you have very marked radial deviation of the thumb. The treatments for these children is, when you can find it, they really do benefit from having somebody offer them cranial distraction, which is like Lizarov for the head, so to speak. So they just open up the mid face and allow better brain development. And then it's definitely one area where, for persons who do go into it, the decision making for hand surgery for function must be done before school age, and it's quite crucial. The feet may be webbed as well with the same degrees of complex syndactyly, but there's not much of a hurry to treating the feet because you just need to be able to fit them in shoes. We rarely ever go around barefoot showing our shoes off. Downs has quite some interesting orthopedic aspects. Now, this is trisomy 21. It could be either due to translocation, in which case you have 3 copies of chromosome 21 in one cell, or sometimes mosaic, in which case you have individuals again who have some normal cells and some trisomy 21 cells. The ones who are mosaic, of course, do have milder forms of presentation and less severe problems. The classic things about Downs is the simian crease, which is a single palmar crease across the palms instead of the normal 3 creases that most people have. They could also have congenital heart defects as well, and they have marked joint laxity, marked hypotonia, in addition to a low intelligence quotient. Because of the joint laxity and the hypotonia, their orthopedic treatments can be quite difficult. The spine, it's important to recognize this and to fuse it promptly. They are not really candidates for bracing per se, in my opinion. The hip dysplasia is quite difficult. We have somebody who's unmuted. The hip dysplasia is quite difficult. feedback noise, and I'm not quite sure why. Hello, Dr. Shupade.
Yes, I'm trying to unmute the person, please.
Oh, good. It looks like somebody is at a party. I thought we were all on lockdown, afraid of COVID and all that. Okay.
Sorry about that. I'll unmute the person.
It's fine. So hip dysplasia, the decision making is difficult because you have a hip that will sublux because the joints are lax. And if you operate on it too early, the joints are lax, so the hip will sublux again and essentially ruin your surgery. Now, if you don't operate on it, the joint will sublux, the head of the femur will get damaged, and then you try to put it back with a more difficult operation, and then it would sublux again. So they're quite difficult in terms of decision making. The foot deformities, essentially, you just brace them and don't operate if you absolutely don't have to. Neurofibromatosis, we all know a lot about, so I will not talk so much about it, except just to mention that in people who have things like pseudoarthrosis of the tibia, it's worth looking at the skin to see whether that is somebody presenting with a distinct bony lesion from neurofibromatosis rather than just somebody with isolated, congenital pseudoarthrosis of the tibia. We know that this type 1s that tend to be more common. Sometimes we get them and we manage them as required. The type 2s tend to happen in people who have, you have progressive walking difficulty, progressive problems with hearing, progressive problems with vision as well. And essentially you could have any of these problems with all the OMAs listed in different parts of the body. So getting to decision making, like I said earlier on, it's important when you have children who just don't look right to take a chance and stop and wonder if you are perhaps missing a skeletal dysplasia. Again, when you find an x-ray that just doesn't quite look like the typical Blount's or the typical rickets, also to wonder if you're missing a skeletal dysplasia as well. It's important to be sensitive when, thinking about these possibilities and when discussing with the parents, because you don't want to, for instance, tell a woman who's having her first child at the age of 52 that you saw something like standout feet and you're sure the child has Downs. This is actually a scenario that happened with a pediatrician. And of course, the woman's blood pressure went haywire. But you must also be able to discuss your concern and perhaps suggest the need for trying to make a genetic diagnosis when, required. Now, we do have labs like Pathcare, like Nelson Lab, able to offer some specific genetic diagnosis if you can tell them what genes you're looking for. I have no affiliations with Pathcare, by the way, but that's the only lab I know for now in Nigeria where you might be able to get a bit of genetic work done. The only trouble is you need to guide them and tell them what gene you're looking for. They can't just, do a panel and give you an answer like you would maybe get if you were abroad, for instance. Now, we know we need to make x-rays or do x-rays for this patient, but one has to be very cautious about radiation dosing because these are children who would come and go. You might have to x-ray them from time to time. So there's really very little room for doing a skeletal survey just to see what the feet are like, because you're not going to manage, the feet. You put them in braces. So what's the point of seeing what that is like, or just checking the skull, or just doing a spine x-ray and so forth? You should always get the opinions of the physicians, particularly the endocrinologists and the neurologists, because some of these problems that come to us have quite important endocrine abnormalities or medical problems that are associated with them that need to be looked out for, managed on their own merits. And honestly, your coxa or genu would not harm you, but nephropathy or a cardiac problem could kill such a child. So it's important to always collaborate with people when we have such children. Physiotherapists are very important and very useful. When we have occupational therapists as well, they can be very helpful with helping to retrain or helping to, improve function and so forth. It's useful to prognosticate and then be able to tell the parents, oh, so we expect that we'll lengthen this child 3 times during, his childhood. We have to try to, see each other every 6 months. We have to be friends through this sort of thing. Essentially draw up a plan and carry them along so that they know what is going to happen and they just don't disappear, with your 8 plates and go away for 3 years kind of thing. And it's important to realize that you must follow up these sort of problems until skeletal maturity. And I suppose even at skeletal maturity, you may then need to think of liaising with some adult colleagues to hand over their care because they may go ahead to have other issues that would still require management and they need to know where to go to. Perhaps for the ones already have implants and so forth in them. The key things you require for a lot of skeletal dysplasia is after good decision making, you need to be able to do things like guided growth, you need to do a lot of castings, some bracing, some open reductions, depending on what the joint is, some fusions, implant removers, and of course, you need to know when to let well alone and do nothing and just watch. So we'll take a short quiz and I'll hand over to Dr. Adedapo after the quiz. I'll just put up a few x-rays and I want people to type into the chat boxes what they think is going on. So diagnosis plus or minus why you think that is the diagnosis. And we'll have about 30 seconds for each one. And then we'll do a quick recap for people who want to go over their answers again, change their minds and so forth. So it's all optional, but it would be helpful just to see whether at least 5% of the lecture was useful, which I think would be just great. So any answers in the chat boxes? Nobody's typing anything. Okay, there's something coming up. I'm not sure whether the person is just saying thank you for your lecture. So I'll go on to the second one now. So this is a second set of x-rays and it'd be nice for us to just say what we think it is. Just label them case 1, case 2, just so that we can know which answer is which one. Sorry, I can't pick up on the chat boxes just yet because if I do that, my screen would freeze. So this is the second one. And this is the third one. So just a little note to say what we think this is for number 3. And I can go over 1, 2, 3 very quickly. So that's 1.
Quick
That's
comment. Somebody
2.
said DDH. I think you need to clarify,
That's 3.
make it very clear that there's no DDH in anything you've shown so far.
Okay, so if they say why they think it is DDH, so that we can take it from there. Okay, so I'll go through. Now, there are no right or wrong answers, but what I want to try and emphasize is like a rational way of thinking through these things. So in this first one, for instance, we can see broad metaphysis. We can see that this is extruding. There's marked collapse of the epiphysis in this particular patient. More worse in the central areas. It's bilateral, quite all right. So your differentials here, I'll think of Perthes, honestly, before I think of an epiphyseal dysplasia. Because epiphyseal dysplasias, like I said, you expect to have small epiphyses. They'll just be small, almost even non-existent. You could have compensatory problems in the metaphysis when things are long-standing enough, I agree. But I would think more of Perthes for this case because of the obvious metaphyseal changes, the fact that this epiphysis is broad, suggesting more of a coxa magna. It's flat, suggesting a coxa plana as well, rather than, a discrete epiphysis that is just in one place. So those would be my thoughts on this. And like I said, they're open for discussion. I'll put up the second one as well. And okay, my screen just keeps freezing. I'm not quite sure why. Okay, so in the second one, I'm not quite sure why this is happening. Okay.
Can I make a comment about the first one?
Please.
Because we haven't answered the question of the person who thought it might be DDH. The
Oh,
first
yes.
comment, without a history, it's difficult to say
It's
for
difficult
sure,
to say.
but Perthes is a good diagnosis. Say, for example, you then got a history that they got pain in one leg and were limping, and then maybe a few months later they got pain in the other leg and they were limping. That would probably be Perthes, because it's unlikely that the pain will start in both hips at the same time. So for Perthes, it would usually be one side, then the other side, and usually one side is usually ahead in terms of the pathology than the other side. Having said that, multiple epiphyseal dysplasia is also a possibility. The way you would distinguish the two is you will do a skeletal survey, or you can just do a long leg alignment view of the legs. You can do a long leg view, so you would see the hip joint, the ankle joint, the knee joint, and in multiple epiphyseal dysplasia, you would see changes in the other epiphysis. Now, to answer the question of a colleague who's asking, who thought one of those things might be DDH, particularly this one, the reason it can be DDH is because the socket, the acetabulum, is completely normal. You can't have DDH with a normal socket. So if you go back to that picture, you see the socket is normal and the head is broken, fragmented, and extruded, which you might get in Perthes or multiple epiphyseal dysplasia, depending on the history. So it can't be a DDH because you can see the socket, the saw seal or the top of the acetabulum, the superior aspect of the acetabulum is horizontal. It isn't deficient. It's the head that is abnormal and has grown out of it. So that gives you a clue as to who's causing the trouble. The trouble is coming from the femoral head. So that's why it can be a DDH.
Thank you. The next one, I would say as a clue, whenever you think you can't quite make out what an X-ray is, it does help. And I learned this trick from Dr. Ajiboye, the radiologist. So sit in a dark room, turn off the lights, and then look at the X-ray on the screen. Sometimes you do get to see a bit more by just doing that. Another thing you can do if you don't have a dark room is to just zoom in and enlarge the picture. So I've tried to zoom this and I hope you can all still see. If you look at this quite carefully, you see that you have, some splaying of the metaphyseal region. It's not quite cupped, but it's certainly wider than you expect it to be relative to the shaft. And it's in both legs. And it's in, both distal femur and proximal tibia, and even in the distal tibia as well. If you look as well towards here, you can see what looks like periosteal reactions over the fibula, almost looking like this fibula has broken in recent times and is just trying to heal again. You can see a little bit of a, almost like a, old cortical breach on that side. The tibia as well shows something similar. And if you look at the hands, this is a wrist that's quite wide. If you look at the soft tissue contour, you can see the splaying and the cupping here. You can see a bit of fraying over the metaphysis of the ulna here, and there's definitely some degree of widening of the physis. So if I put these things together, I would think of rickets, with old fractures or recurrent fractures. You would also think of something like a metaphyseal chondrodysplasia, such as the Janssen type, which we spoke about, which tends to be a very good differential for rickets. So my thoughts here would be rickets because of that. Why don't I think it's more of a metaphyseal dysplasia? Because the metaphyseal dysplasias don't usually have recurrent fractures. If they would fracture, you can have bowing that becomes severe enough to a point where you actually fracture. But you wouldn't have this sort of rickety pattern with, fractures. And then, of course, these little lines just suggest increased metabolic activity. You can find them on both sides as well. So those would be my thoughts for the second one. The third one, by comparison, there's definitely an abnormality of the metaphysis in this particular child. And again, we can see that this is affecting both the distal femur and the proximal tibia. Even the proximal fibula as well doesn't look normal. But the epiphyses are fine. They have a nice rounded appearance in all the bones that we can see. Similar problems, the metaphysis over the hands as well is also similarly abnormal. The physis is not particularly wide. The wrist is not as wide as that other child we saw. And again, we can't see evidence of fractures here. So my thoughts here would be that this is a child who has got some type of metaphyseal dysplasia. Okay, you also want to check the spine and see whether it is a spondylometaphyseal dysplasia and so forth. Those are my thoughts. I think we had Dr. Bafo's hand raised earlier on to comment. I'll just say, please unmute yourself, sir, and I can hand over to Dr. Didapo to take the next hour before we take up too much time here.
Okay, thanks, Kemi. I was just going to mention that for your first case, I would want to see the spine first before making an impression of multiple epiphyseal dysplasia, because as you know, spondyloepiphyseal dysplasia and multiple epiphyseal dysplasia have very, very similar radiologic features when you look at the epiphysis. Usually the difference is when you look at the spine. In SCD, there is involvement of the spine, and this is absent in MED.
Yes, thank you very much. So it's always crucial to look for the spine because that does add a bit of extra. It adds Dr. Shobode to your diagnosis in summary. Dr. Didapo, may I hand over to you now, please?
Yes, thank you very much for an excellent talk. I hope it was taken to heart. I specifically wanted, I preferred that this was done before we talk on Blounds because my experience has always been that quite a lot of things in this environment get called Blounds that are not Blounds in West Africa. So I think it's useful to have had that initial excellent talk so that people can be aware that lots of things can make a child's leg bow, and it's not necessary that it is Blounds in the strict definition of the word. I'll see if I can share my slide, share screen, that one, and share. Thank you very much, everyone, for coming and spending your afternoon here to listen to what we have to say about Blount's disease. I am no expert in this area. I am learning a lot along the way. We don't have a lot of this in England. Blount's, it's a Black people's illness. So you won't find very many people who will come from the UK and tell you how to treat Blount's. One of the things that I found being here, sorry, I'm not sharing my picture because I just wanted you to concentrate on the screen to a large extent. One of the things that I found since coming to Africa and working on children over 10 years now is that rather than we being at the forefront of the science and treatment of Blount disease, we're actually way behind. And we should be telling everybody else around the planet what to do with this condition. And we haven't been doing that. And I'm just hoping that part of my reason for this talk, apart from hopefully learning from everybody else and sharing what I've learned over the last few years, is hope that I can stimulate debate and perhaps collaboration as to what we should be looking at in terms of studies to move this condition forward, increase public education, and improve the outcomes for the patients who are suffering from this dreadful disease. Blount's disease, the scientific name is osteochondrosis deformans tibia. It's a bit of a mouthful, but it tells you exactly what it is. It's a pathology of the growth plate of the proximal tibia that leads to a deformity of the tibia. If you understand it in those terms, you're beginning to understand how to treat it. It's a growth plate problem, period. There may be reasons why the growth plate had a problem, maybe primary or maybe secondary. Again, those are some of the things we should really start working out in our environment. Is it a primary pathology of the growth plate that causes Blount, or is it the mechanical environment that that growth plate is put under that makes it become pathological and then sets up the Blount process? So 3 people described it a long, long time ago. Blount gets the credit for the name for the condition, but he didn't describe it first. He just happened to have been the one that wrote in English. Because if you see my references, these other 2 guys, Mao and Nilsson, they described the condition, Mao in 1923, but that was in German, and Nilsson 1929, that was also in German, Acta Scandinavica. So they didn't make it into the English language literature. So Blount undeservedly gets the credit for describing this condition because the English language obviously is read more widely. If you don't, I just thought I would talk about 2 or 3 things you need to understand if you are ever going to get to grips with this condition. If you don't understand these things and you don't understand them reasonably well, you cannot treat Blount's. First thing you need to understand is the growth plate. This is the growth plate in the proximal femur. It's a schematic diagram that I did. If you're talking about the tibia, just assume that that head is flat, and that will be your proximal tibia. You need to understand where the blood supply to the growth plate comes from, the nodes of Ramvier, the resting cells, which are very, very close to the epiphysis, which are the ones that generate the other cells that allows longitudinal growth to take place. Circumferential growth takes place from the perichondrial ring of Lacrosse. That's what allows your bone to get wider or bigger. The transverse growth plate or the horizontal growth plate, this one, allows your bone to get longer. If you interfere with any part of that growth plate, you will get a growth abnormality. So if you interfere with the growth plate on this side, the bone continues to grow on this side and doesn't grow on that side, you get a deformity. You can interfere with the whole of the growth plate and then you get complete growth arrest and that bone doesn't grow in length. There's a little bit of growth that takes place, but largely the growth in length is stunted. You will get a widening of the bone, but it won't grow in length and it will be smaller than the other side. That you need to understand. It sounds fundamental, but it's impressive how often we continue to forget this basic, very basic principle. The other principle you need to remember when you're treating Blount is the Hutter-Volkmann's law. He's a German surgeon, and it's an orthopedic rule that states that bone growth is retarded by increased mechanical compression and accelerated by reduced loading in comparison with normal values. So if you squash the growth plate, put a lot of pressure on one side of the growth plate, that side stops growing. That's the principle of an 8 plate. You just hold it and put pressure on it, doesn't grow. And then the other side that you haven't put pressure on grows normally. If you put traction on the growth plate, then it grows quickly. That's what we call chondrodiastasis. De Bastiani and his group, a long time ago, the people that went on to design the orthofix fixators, they used to do leg lengthening through the epiphysis because the growth was really quick. So you put wires or pins into the epiphysis and the metaphysis, and then you pull it apart. and it just grew like crazy. I mean, you could lengthen the tibia or femur quite quickly, but then you'll get 3 centimeters or thereabout, and then the physis will shut down. The growth plate does not like to be messed with. And then if you wanted to grow 15 centimeters, you couldn't, or 10 centimeters, you couldn't, or even 5, you couldn't grow it reliably, but you got some growth. So that's why we stopped doing chondrodiastasis largely. Every now and then people still do it if they just wanted to grow a little bit, particularly when it's towards the end of growth. The other principle, that this is just to say chondrodiastasis, you can grow very slowly, and grow a short segment, and then it will arrest. That's it, you're done. The final thing you probably need to understand before you get into treating Blount's is you need to understand the concept of mechanical axis of the lower limb, because that's where the weight of the body goes through. So center of the hip, center of the knee, center of the ankle. That's what it's supposed to obtain. Now, if you have a lower extremity that's in varus, it means that the mechanical axis line in the frontal plane falls into the medial side of the knee joint. In a lot of the Blount's cases we have, it actually falls outside the joint. It's out here. That puts a lot of pressure on the medial growth plate. If you are putting a lot of pressure on the medial growth plate in that sense, that way, you're not going to get a good result no matter what you do. You've got to take the pressure off the growth plate so it can recover. If you don't take the pressure off on time, the growth plate will fuse. Once the growth plate fuses or seizes up, as far as Blount's treatment is concerned, it's game over. If you get a massive physeal bar, especially if it's a big bar, it won't recover. You're now into deformity correction, leg lengthening, and the rest of it. What you have to do to get the child back is a lot more. This is, I think everybody should read this article if you can access it. It's by John Birch. John Birch is probably one of the foremost Elizarov surgeons in North America. He works at the Texas Scottish Rite Hospital for Children, and he wrote this in the Journal of the American Academy of Orthopedic Surgeons, 2013. I won't read all of it, but I'll just summarize it. He's talking about Blount's disease, a progressive tibial varus deformity observed in otherwise healthy children and adolescents. And then I'll go down to really pretty much what I have found working in Africa. Texas has a large Black community. A lot of the children that come to that particular hospital are Black. So he says, infantile Blount disease may resolve, this is a summary of my talk, respond to non-surgical treatment, or be relentlessly progressive. So the surgeon must be astute in recognizing the features of true infantile Blount disease to determine effective treatment options. And this is, I think, where we come in as Nigerians and as Africans who actually have the burden of this disease, is determining effective treatment options. I'm talking about effective treatment options early so the child can have a normal life, not massive frames, because this is what this guy does, and he's obviously not very, very happy with the current state of play. So it's up to the younger surgeons to try and make the treatment of this condition better. I think of Blount in terms of the same way we used to talk about Ponseti, and people used to, a lot of people didn't have any time for Ponseti, and all they wanted to do was operate, until Ponseti found a nice, simpler way of doing this, kinder to the children, and worked for most people. And I think that's what we have to do for Blount. There are 2 types of tibia vara Blount's disease. I call it the early onset or infantile Blount, and then there's the what they call the adolescent Blount. Some people put a juvenile in the middle. I think it's a spectrum, and I'm not terribly pedantic or religious about it. There are some that start early. This is the vast majority of the ones that go on to be really, really bad and give us a lot of headache. But even the adolescent ones as well can be quite tricky to treat because they don't generally respond to some of the treatments that we attack them with. The early onset Blount, they say it starts at 2. I think it starts earlier than that. And I think by the time the child is 2, 2.5, you're beginning to tell whether this one's going to respond to treatment correct spontaneously or not. So the first step and the first question we need to answer is, are there signs that a child will show at the age of 2, 2.5, 3 that are early warning signals that tell us that this bounce is going to be really, really bad and we need to do something early? And in my time here, I think that there are, and I think that is one of the areas that some of the teaching hospitals and people that see high volumes should actually start to do studies on. Elliot said infantile bounce is bilateral in a significant number of patients, not invariable. I think 50, 60% easily is bilateral. In fact, if you have a unilateral bow leg, is one of my indications for saying that this is going to be severe and this will probably progress. So bilateral versus unilateral. Unilateral is more likely to do badly than bilateral in general. If the bow leg is a proper blount, in my opinion, I don't think blount gets better. I think physiological bow legs, they get better. You give the child 6 months and physiological bow legs recover quickly. If you see a child at 2 and you say it's physiological and it's bilateral and you decide that that's physiological bow legs, if you do, then you ask the child to come back in 6 months and you want to see the child again, you have to make it very, very clear to the parents. They must bring the child back. The trouble is, there's one thing that's fundamental about treating these children well is education, parental education. It's always better if the mother comes with somebody else, not that she comes by herself. Because if she comes with somebody else, that somebody else will remind her that actually they said this child must come back. Because if you don't bring this child back, this leg gets worse. This will be very, very difficult to treat. Now, if they come back at 2.5 years old, the leg is still bowed. My suggestion is, of course, you're going to do an x-ray, and there are things that you look for in the x-ray as well that tell you this is not going to go well. But if they're coming back after 6 months when you thought it was physiological, it's 2, 2.5 is worse. If you're waiting for it to be 3 and it's worse again, by the time it gets to 3 and you want to start operating, you're going to have to do a little bit more, perhaps even a lot more than you would have done when the child was 2.5. This is the trouble. The surgery just becomes a lot worse, a lot more difficult, and your outcomes are worse, the worse you allow the condition to become. There's a whole range of differential diagnosis for blount disease, and I'm glad we've gone through those already, and that was absolutely excellent. Rickets, osteogenesis imperfecta, MED-SCD, these in general will cause deformities bilaterally, the first 3. Metaphyseal dysostosis, Schmidt, Janssen, again, often these are bilateral, sometimes unilateral. Focal fibrocartilaginous defect, that's often unilateral. And the other 3, the bottom 3, are often unilateral. And these can cause tibia vara. So the trouble with some of these conditions is, like, for example, that focal fibrocartilaginous defect. Now, you can do osteotomies until the cows come home. If you don't remove that, that's almost like a physial bar. If you don't remove that defect from the growth plate, the deformity will continue to recur and recur and recur. So when you keep getting recurrence, you think that it's you that's not doing a good job. No, it's not that you're not doing a good job. It's that you need to go back to your understanding of the growth plate. If it keeps recurring, well, the growth plate has a problem. That's why it keeps recurring. What's the problem? You got a physial bar. What is the origin of the physial bar? Either you've got a congenital abnormality like this metaphyseal dysplasia or fibrocartilaginous defect, or you've got a bony bar because the pressure on the growth plate has gone on for too long and it's fused on the medial side. And that happens. And that can happen easily by age 4 or 5. And that's it, you're done. You're now in a lot of trouble. This is a review of the literature on focal fibrocartilaginous dysplasia and tibia vera. This was published in the French language, and it's worth reading. I suspect we have a lot of this. We haven't written about it because we haven't done our own homework in terms of adding to the body of literature on some of these conditions. Lagenskull classifies the Blount's conditions into 6, and basically the classifications are just a progression of the distortion and damage to the medial tibial, proximal tibial growth plate. In the first group, we talked about irregular metaphyseal ossification, and in group 6, it says there's a bone bridge across the physis. Okay. Now, by the time a child is coming to you with Blount's, they refuse to come back to clinic at age 2. They come back at age 5 or 6. They will have a bone bar. They will have a bone bridge across the physis. All the osteotomies in the world you're going to do will never, ever fix that problem. You need to recognize there's a bar. It needs to be explained to the parents there's a bar, and it needs to be told to them that the operation you're going to do, that they're going to pay a lot of money for, is not going to work. It will come back, and it'll keep coming back and coming back until you do something about that bar, if you can. And that has been my experience here. Lagenskull did his classification in 1952. As far as I'm concerned, it's not very useful for us here, because you're looking at it and it's not actually, doesn't quite tell you what to do with these things. You read some of the literature and they tell you group 2 and group 4 will progress, group 3 won't progress. Why would you have a classification where 1 is maybe not very much happening, is epiphyseal dysplasia, 2 and 4 will progress, 3 is not going to progress? I mean, that's just disjointed and doesn't help your understanding of the condition. Again, this is an area where some collaboration among our colleagues would be helpful. Let's just get a lot of Blount's children's x-rays together, find out what the outcomes were, and then start deciding on how we are going to classify it in terms of who's responding to treatment, who's not responding to treatment. This classification isn't helpful. The only thing that's useful is whether you're a 1 or a 6. If you're a 6, you've got a bone bar, or is it 5, 6, yeah, you got a bone bar. 1, you haven't got a bar. That's the only class. That's the only way I can use this particular classification. That one. Okay, because on the x-rays, you can't quite tell. By the time you get into 4, some of the 4s have already got a bone bar or a growth plate tether on the medial side. So they will not respond to a simple osteotomy. Some of them will not even respond to an 8-plate application because the physeal bar is just holding it absolutely rigidly. So 3, 4, 5, 4, 5, 6, not very useful at all. The metaphyseal diaphyseal angle. You measure the metaphyseal diaphyseal angle in this way, and it says, if your angle is less than 11 degrees, you have normal physiological bowing. If it's between 11 and 15 degrees, it's equivocal. Greater than 15 degrees is Blount's. Now, for the guys that are going to do exams, you need to know these things and just cram it. When you come out into practice, to a large extent, it's absolutely useless because it gives you false confidence. So you see a child, for example, unilateral bow leg with MDA of less than 11, and the child is already 3 years old. You're going to send him away with no treatment and no follow-up. Wrong thing to do. It's going to progress. It's going to come back at 5 or 6 and bite you in the behind, because the treatment then will be absolutely, absolutely difficult. So this alone is not useful. You need to demonstrate that that condition is either getting better or getting worse. And the only way you can do that is by following up the child, doing serial x-rays, 4 to 6 month follow-ups, serial x-rays over about a year, if the child is young enough. If the child is over 3, I wouldn't use any of these things. Anybody over 3 with a tibia vara that has not corrected and changes in the growth plate on the medial side needs surgery, okay? Certainly in this environment, that's what I've found. Blount's can be inherited. It's an autosomal recessive gene, which means that for the child to get Blount's, both parents have to be carriers. Both the mother and father have to be carriers. How do you know who's a carrier? You take a family history. Did anybody have this leg in your family? Yes. Did it get better? Some of them got better. Some of them did not get better. You have to understand that the genetics doesn't mean that the Blount's won't improve. The genetics simply means that if you do get Blount's, if the mechanical environment is not right or is not corrected quickly, then you'll get a severe form of it. Treatment for early onset Blount's, you can observation, like I said, if you see a child for the first time, it's 2 years old, you've got the opportunity and the confidence that the child is going to come back and see you, you want to wait 6 months, see if it gets better. You wait 6 months, both the x-ray changes and the child are worse. Okay, you want to wait another 6 months. It's going to make your treatment a lot more difficult because your mechanical axis will get worse in that time and your growth plate will get more damage in that time. Fine, you can wait. It's a child, you know. So you come back in 3 years and it's still a little bit worse and you're arguing with your colleagues, is it worse, is it better? Once you're starting to ask yourself, is it worse, is it better? And you and your colleagues are not sure whether it's worse or better. It's worse. You're doing that child a disfavor by continuing to watch that child because they will go away. They will say you don't know what you're doing. Next time you see them, they'll be 5. You've got a bar, a physial bar. That's what you will have. That's difficult to correct. Bracing as a treatment for Blount. I personally think if you're going to use a brace, you have to use a brace by age 2. They have to wear the brace all the time except when they are asleep. You need to take an X-ray in the brace and see if the brace neutralizes the axis, if the brace makes the mechanical axis neutral or valgus. If it doesn't put it into at least neutral, that brace is useless. It's not worth the money that they've paid for it. Those braces can be quite expensive. So if you don't use it early enough, and if you take an X-ray in the brace, you don't have a neutral or valgus mechanical axis, it's a waste of time. It's a waste of the child's time. I actually think braces are cruel and no one should have to use them, especially when we don't know what we're doing. Surgery, guided growth correction is the mainstay of treatment if you find the child early. So between ages 2 and 3.5, they work well. By the time you kind of see the kind of Blount you guys get here, you're treating a 4-year-old. It's not very often you'll get a 4-year-old to respond to 8-plate alone. If you want to use 8-plate alone, you want to be using a lot earlier than that to get the kind of results you want. This is the kind of brace for Blount. If you put your brace on and you don't alter the mechanical axis, so this child should get an X-ray in this brace to make sure that you have neutralized the mechanical axis, is dead straight or slight valgus preferably, so that you are now throwing the load of the body weight through the lateral tibial plateau rather than the medial tibial plateau. So the medial side gets a break and gets a chance to recover. You're offloading it, and according to Hütter-Volkmann's law, you should recover. If your brace doesn't do that, then pointless. You can see that this is a rather small child. It's still got pampers on, which means, I suppose for a girl, which means that it's definitely 2 years old, perhaps a little bit less. For a boy, they tend to wet themselves a bit longer. But the point is, this only works in very small children. There's no point bracing a 4-year-old. It's a total waste of time. Absolutely total waste of time. Those are the kind of x-rays you should be getting for Blount. Unfortunately, it can be difficult for us to get those. You should get a long leg alignment x-ray. This is what I keep talking about. If you draw a straight line from the center of the hip to the center of the ankle, you can see that that straight line falls completely outside the knee joint on the medial side. So when this person walks, they will walk with a varus thrust. You can see the slope of the tibia plateau on the lateral sides. Look at the slope on the medial slide. Look at the beak of the tibial metaphysis. This Blount didn't. This is one of those ones you call the late onset ones. This one didn't start at 2 or 3, because if it started at 2 or 3, by the time we get to this stage, this would be a lot worse. This started a little bit later. So like I said, it's a spectrum. It's not like early onset Blount, infantile Blount, I must start at 2. Or late onset Blount, adolescent Blount, I must start at 10. Actually, for this condition, I think in our environment, they do start at a whole spectrum of age group in childhood. So it's not one particular age that starts it. So some people start at 5, but you wouldn't notice it at 5. By the time they get to 8 or 9, the parents notice, oh, his leg is a bit bent. And then you're thinking, is this adolescent, is this infantile? I think it's all a midpoint. I think it's a spectrum in our environment, definitely. This is the kind of picture you will get when, everybody keeps telling the family, it will correct, it will correct, it will correct. This is not a weight-bearing view. When this child starts weight-bearing, this leg is severely bent. You can see what's happening to the growth plate on the lateral, on the left side, on the lateral medial growth plate. Look at the right side, it's not nearly as severe. This is the kind of work we need to start doing. How bad does this have to be for us to decide whether an 8-plate and osteotomy is sufficient or whether we need to do an epiphysiolysis? I reckon on the left side, just simply doing an 8-plate is just not worth the trouble because your mechanical axis is so way out. On this one, the mechanical axis is about here. On that child, the next slide, his mechanical axis is probably in the middle, in between his legs. So if you get that amount of pressure on that medial growth plate, well, it's gone. It's just not going to recover. Okay. So these are some of the things we need to think about. Look at this on the other hand. That leg, when this patient stands, is slightly bowed. You can still follow that tibial growth plate almost to the end. You know, this one, you follow it to about 2/3 of the way. Should we be measuring things like that? That's something for one of the senior registrars to be looking at for their project. Should we measure the growth plate from there to there and see whether it's equivalent to the length of the tibial metaphysis, distal femur? How long does it have to be before we decide that this is going to be an absolute problem to deal with? These are some of the things we need to answer. So when these kind of children stand, this is an attempt at standing before they shoot an x-ray. There is no medial tibia plateau, it's gone. And then you want to do an osteotomy and expect this child to be okay. Or on this side is worse, it's broken off. This one's probably worse than this because it's past this stage. At this stage, that tibia plateau, that growth plate broke off and he's still waiting for somebody to come and rescue him. Nobody came and it's become like that. So when you see that, you think that's better than that? No, that's probably the end stage. There, you got a physial bar. You do an osteotomy, even with an osteotomy and 8-plate, this is too far gone. And this child is only about 4.5, 5 years old. The child's 5 years old. So you've lost. Tibia is going to be short. Growth plate will be shut down. You could have put an 8-plate on this child at 2.5, avoided all this trouble. Now we're struggling. And that's a similar one. But you get a lot of this. And then you're wondering, oh, Blount's is bad and the treatment is bad. No, we're treating them too late, way too late. We're allowing the growth plate to be absolutely and completely trashed before we get near these children. So you do an 8-plate for that kind of, look at that. So you do an 8-plate for this kind of deformity, put an 8-plate in, and this is what you're going to get. You're asking, this is the only place where it's growing. There's no growth taking place there. So it grows and it snaps. And then you get a distal femur deformity in addition as well, just as if you don't have enough trouble. And now you have a horizontal growth plate, the bit that's left. You have a horizontal joint line. In fact, not just a horizontal joint line, you have a 90-degree joint line. So lateral plateau is horizontal, medial plateau is vertical. So there's no amount of osteotomy you're going to do here that's going to correct that. You can put all the frames you want in the wall. You need to correct that joint line, make it horizontal, and then you need to put the joint line, tibial joint line, you need to make it horizontal as well. Instead of half a tibia, the whole of the tibia articular surface needs to be reconstructed, and everything needs to be made horizontal. Ideally, obviously, you will need a long leg film before you start, if you can get one. If you can't get one, well, get on with it. So these are the problems we get when we don't do what we're supposed to do when we're supposed to do. We just get bigger problems, much bigger problems. This is the kind of problem we get. You get physial bars and depressed growth plate. Usually when I see these kind of cases, I take a long, deep breath. And then in the old days, you think, oh, I'm just going to use a C-arm. I'm going to put dye in, arthrograph dye. I know where everything is. Total waste of time. I don't even bother myself anymore. I just open up the medial side of the knee joint. This one is not the worst I've seen. You can see the depression. This is where the lateral tibia plateau is. This is the medial tibia plateau. The angle between both of them, something like 120. Instead of being just a straight line, this is making an angle of about 70 degrees from where it's supposed to be. It should be here. It's down here. Then you got a bar here. So there's no amount of straightening of this leg you're going to do. you will never correct the joint. So you'll have to come here, resect the physial bar. You have to keep going until you see the growth plate. Once you see the growth plate, then you do an osteotomy below and parallel to that growth plate, right into, almost into the joint, into the growth plate, almost on the lateral side. And that whole thing needs to be elevated. So you create a joint line that's transverse. It can be a big hole, depending on how badly depressed it is. Now, if you don't do this, in fact, sometimes you do this and you find the leg is straight, because a lot of the depression is on that side. And then you've got to put a big wad of bone graft in, and then support the articular surface, the subchondral bone of the articular surface, sometimes with screws, sometimes with K-wires, sometimes with a plate, depending on the age of the child. But you can see the size of bone graft that I had to use to support the articular surface. And once you've done, the articular surface goes to something like that. I could probably have made it better by pushing it up a little bit more, but I didn't have a big enough bone graft. So that supports the articular surface. That's my bone graft. There's a great big hole here, a defect that's been filled with graft. And then that supports my graft. And these children, these K-wires, this kind of K-wires that are close to the joint, you have to bend and bury under the skin because you don't want the joint getting infected. And I would leave these wires in 6 to 8 weeks and then take the wires out and put a long leg cast on, probably for another 4 to 6 weeks because I don't want that to collapse. Now, the trouble is, if you're having to do this much to correct the articular surface of the joint, what are you going to do about the medial side? It depends. If the growth plate is open and you think that you've managed to remove the bar completely, you can leave it alone, or you can do a temporary MA epiphysiodesis with an 8-plate. You can put an 8-plate there, just so that that tibia stays straight for the next 6 months to a year. Once 6 months to a year has occurred and there's no pressure, you would see signs whether it wants to drift back in the varus or not. You can take your 8-plate out. So these are really difficult problems and difficult challenges that we're all facing all the time. That's a lateral view. You have to get a lateral view because you don't want too much anti-curvatum. You don't want the articular surface either tilted anteriorly or posteriorly too much. You want it anatomical. Late onset Blounts, I think they start about 7 or 8. I don't think they start 10 or 11. I think they start slowly, 7 or 8, and they develop more slowly than the younger ones. The children are usually overweight or obese, but this is not always the case. There are skinny people with Blounts. Often it's unilateral, but a significant proportion is also bilateral. They can become quite bad, but the difference between the early onset and late onset is the articular surface depression is not nearly as severe in general in the late onset Blounts. Once you get into these late onset Blounts, very often they would develop quite a lot of them, and the early onset ones that are not treated on time would develop significant deformity of the femur. So you'll have to start thinking seriously about doing tibia and femoral osteotomies. If you catch late onset Blounts really early, say like 8, and the deformity is not severe, you can try an 8-plate, but my experience has been 8-plate for late onset Blounts in isolation often doesn't work. You have to correct the mechanical axis. If you don't correct the mechanical axis and put the mechanical axis into valgus, your 8-plate will not work because the pressure on that medial growth plate is significant. This is an example of what I suspect was a late onset Blounts because the deformity wasn't there as a child. It started a bit later. And by the time we saw this person, she was already in her early 20s, 21, 22. And this is what you get. Both legs were similar. We had corrected this side, I think I think we corrected it October or November, something like that, about 3-4 months ago. And she was absolutely desperate to have the other side done. Remember, we had a talk last week about flat foot deformity and the deformities in the foot with Blounts patients. Again, this is where you start to understand the difference between early and late onset. With the early onset Blounts with severe deformity, the foot deformities don't correct after you line the leg up. With the late onset Blounts, if you correct the deformity the foot often doesn't need anything doing. You can see the foot's completely lined up, not giving any trouble at all. She's absolutely desperate to have this knee done. This knee is now painful. Both of them were painful before. And this is the point I was trying to make. The late onset blounce, you can see the articular surface depression. This is her standing. The articular surface depression isn't nearly as severe as if you get an early onset one. This is an early onset blounce that a much older person, this child is now 15, 16. You can see the horrible depression of the articular surface. So they do come in varying severity. The surgery you need for this and the surgery you need for this is different. The same operation will not work for both. You have to design your osteotomies ever so slightly differently. This is what I would often do with some of these conditions. I would elevate the tibial plateau, put a bone graft. This is a growing child. So that, again, that intra-articular osteotomy was done here with a wedge of bone graft. Sometimes the wedge is actually quite secure. And then you will do a tibial osteotomy below that to restore the mechanical axis of that femur. So lots of varieties of operation. This is what I would do in this one. This is what they had. They had a closing wedge femoral osteotomy to make that joint line horizontal, to get a joint line normal. You have to normalize the joint line. You have to do it. You can't do your intra-articular osteotomies, hold it with a screw and then put a frame on, but the frame will not line up your joint for you. So you put your joint line horizontal, make it a normal joint line with a distal femoral osteotomy, closing wedge. Often that's what I do. So I just do it. And then you correct the tibial deformity. In those older people, I'll use a plate for both. I just use a standard 4.5 DC plate. I don't use anything fancy. And I use a T plate because it gives me more screws. Why? Because it just gives me more screws proximally. And there's a wedge of bone graft. The wedge that I take out of the femur, I put it in the tibia. I get a horizontal joint plate. Everybody wins. Femur wins, tibia wins, joint wins, leg is straight. We all go home. This is what these legs look like. They look really horrible on the table. This is just another case. And again, this is a femoral osteotomy, tibial osteotomy. That's my saw. But you can't use some of the saw blades we use for knee replacement and hip replacement in these conditions will not do because they vibrate too much, they're too powerful, all over the place, the bone scatters. You need something really fine, really light, because the cuts are precise. The wedges are precise. How do I work out the wedges? I kind of look at the x-ray for a very long time. I can draw it out. In the old days, I used to draw out the bones on a piece of paper, and then I'll cut around the piece of paper, and then I'll cut the wedges in it, and then I'll line it up, and then I know what I'm doing. I think that's a good way to start. But when you cut too many legs, you just kind of cut it, and then you go, that's enough. Yeah, that's it. And that's one osteotomy. Then we did the tibia side. Then that's the leg when we're done. So you do get this kind of results. You can get this on the table. When you do your tibial osteotomy, please take a little sliver of tibia off to give you room to move. Don't force it. If you force it, you stretch out the neurovascular bundle, particularly the vessels, you will get a compartment syndrome. You will be sorry for yourself and for the patient. This is what the x-rays look like. This is what I was talking about. You must get a joint line that's horizontal. And these are the x-rays for after the osteotomies are done. In this particular child who wasn't fully grown, I didn't want growth to be disturbing me again. So I think this one was about 15. So I put an 8 plate on for security. And this is the older person we did, that older person that I showed you that we had done one leg. Let me quickly run back to her clinical picture. That's her clinical picture. That's a standing x-ray. You have to get standing x-rays. Otherwise, you don't know the magnitude of the deformity, number one. And number two, you don't know whether the growth plate is horizontal or not. It's important to have that information. And for that, you need standing x-rays. So this is what we did for her. And this is our x-rays. So this is a non-weight bearing x-ray. So it looks like you're okay. No, you're not okay. You get a weight bearing x-ray and then you know that you're not okay. And then you fix what you have to fix. This is another patient that got done, I think, a week and a half ago. And I can only do one leg at a time because I think they're very painful operations and the child needs a break as well. This patient is actually not a child. This patient is 16, 17. And she screamed out in agony for the first 2 days. 3 days later, she's asking for the other side to be done. Still in pain, but wants the other side to be done ASAP. And those are some of the results that are possible. There's a case report that I actually saw in JBGS. This is very recent, 2020. And these same operations that we have to get on with and do, they can only do if they get a 3D printing technology that shows them where all the deformities are so they can know where to make their cuts. We don't have that luxury. We have to learn how to do these things and teach them how to do it without 3D printer. Because I wouldn't get a 3D printer for any of this for a long time. Half of them can't afford it. Some of the patients you are looking at who are done under charity because you can't afford it and you can't just let them keep doing this. So again, this is one of the areas where we need to collaborate and just improve the quality of life of our people. Thank you very much. Questions, please. Sorry, I went a bit quickly because I'm aware of the fact that some of my colleagues want to share stuff. So I kind of just flew through that a little bit. Please ask whatever questions you may. I'll answer them.
Okay, so questions and comments. Meanwhile, I will try to put up the cases that came in earlier on. Dr. Bafo has his hand raised. Please unmute yourself, sir.
Thank you, Dr. Dedapo. I have mainly comments, not questions. Yeah, so Blount's was actually first reported by Erlacher in 1922, not Mao. Incidentally, he also published in the same language, in German. With regard to the etiology, yes, the problem is still that nobody knows the etiology of Blount's disease. It's thought to be a problem. Essentially, it's thought to be more or less like a skeletal dysplasia, and the problem is the posterior and medial aspect of the proximal tibial physis, with affectation of the adjacent epiphysis and the metaphysis. With regards to the types, early and late onset, the evolving consensus is that there are two completely different types of disease. There are two completely different pathologies. In the past, we would describe early onset as starting before the age of 4. Some say 3, but I think most people will agree on 4. And then late onset starts after the age of 4. Late onset, again, divided into juvenile onset and then adolescent onset. The sharp distinction between types is between the infantile type of Blount's disease, which manifests before the age of 4 years, and then the adolescent type of Blount's, which usually would start after the age of 10 years. Epidemiologically, in terms of their features and even in outcome of management, they are quite distinct. The problem with diagnosis in early onset Blount's disease is largely related to the fact that severe physiologic bowing and the early stage of Blount's disease, so the lagging scale stage 1 and 2, which you alluded to as not being helpful, are almost indistinct. Whereas severe physiologic bowing may not progress. Early onset Blount's disease will definitely progress. And that's where your assertion that these patients must be followed up is key. So when you are looking at early onset Blount's, the you cannot separate this from looking at the evolution of the knee angles as described by Vanka and Salinius. Some will say any patient who is bow-legged after the age of 2 years certainly has an abnormal tibiofemoral alignment, the Miculis line. The normal alignment of the knee is such that the Miculis line, which is what you mentioned, the straight line from the center of the hip to the center of the ankle, the normal alignment is that it passes just medial to the center of the knee. And that's invariably in zone 1. In severe physiologic bowing, you may have this line in zone 1 still, or in zone 2. The question is, what do you do? Do you offer these patients treatment or not? Paley, Heisenberg, and I think Anil Bave, they had an article where they talked about defining varus and valgus alignment and what is considered the normal range. So how far from the midline of the knee do you consider normal, and then you offer the patient something. This would probably be helpful in deciding what to do for these patients. Severe physiologic bowing versus early onset Blount's disease. We don't have that luxury, as most people know. A lot of our patients present when they have a physical bar already. But that's just to know. Now, with regards to the Langenskiel staging, so I don't think it's completely useless. It's one of several classification schemes that's available for Blount's. You also have the Smith classification, and John Birch himself from Scottish Rite. His group also has a classification scheme for Blount's. Langenskiel is helpful in the sense that it is prognostic, and it also helps you decide what kind of management to offer the patient. The main problem is with inter-observer variability. And like I mentioned earlier, the fact that it's difficult to separate severe physiologic bowing from the early stage of Blount's disease.
Okay, sir. We need to let our colleagues present their cases because we'll soon run out of time. We're nearly 2 hours now. Thank you very much.
No problem.
Thank you very much. It's amazing how much time has passed. So I'll just put up these x-rays. I've started sharing them already. And
do they want to tell us about the case, or are you presenting it for them?
I have a little case summary. So maybe I should start with that. It's a 6-year-old with progressive lower limb deformity since early childhood, had right supracondylar femur corrective osteotomies 2 years ago, but deformity recurred, and also has some limitation of elbow movements, elbow extension bilaterally. And what do you think about this?
Can we see the AP film, please?
Okay, maybe I can just put them side by side, just so that we can see them at the same time.
Oh yeah, that's great. Thank you very much.
Okay.
Do we have the x-rays before the osteotomy that was done or not?
No, we don't have them. This is all I got sent.
And we don't have any clinical photographs of the child either?
No, unfortunately.
And the femoral osteotomy was done for what?
I said the corrective osteotomy of the distal femur.
For what? What was the deformity? Valgus, varus, rotation?
I'm not sure.
We don't know.
No, not that I know.
Now, is the child weight-bearing or not weight-bearing? A clinical photograph is often useful in these cases, and perhaps a short video,
Yes.
because it tells you what the joint is doing, what the ligaments are doing, and things like that. So I mean, and we don't have any. I suppose there's no point asking whether any genetics has been done or genetic analysis has seen or
I
anything.
don't think so.
I'll just let one or two people make a comment briefly.
I'll say one, like you said, the trouble we have is getting proper alignment views. And sometimes if you don't think you can get good alignment views, there may be some room for having a CT scanogram, which is one shot and which gives you all the information without all this stitching. The other thing is, as much as possible, you need to have x-rays that actually have the limbs in as normal a position as possible, because here we do have quite a bit of rotation. That's not necessarily the fault of the person. It's worth thinking about. And when you think you would struggle, you might have a cone view of the joint itself. So I would have wanted a knee x-ray in this
Well
joint
done.
because the deformities are largely at the knee. It does look like there's a lot of metaphyseal changes here. I just blow it up a little bit. So both the metaphyses of both distal femurs look quite abnormal. The epiphysis as well, I'm not quite sure of, but they do look quite smooth. But there's definitely some metaphyseal dysplasia, in my opinion, going on. What do you think?
Yeah, I think it's one of those epiphyseal or metaphyseal dysplasias. I don't know which one. That was why I was asking for an X-ray prior to the surgery. Obviously, they've done distal femoral osteotomy. I don't know what the knee looked like before the osteotomy. And I don't know whether as a result of the osteotomy or the pathology, it could be either, we've probably got a growth tether on the lateral femoral growth plate. So I think the problem we're dealing with now is, do we have a growth arrest on the lateral femoral growth plate? Number one. Number two, is the other lower limb normal? Is it normal when the child is walking or not? You know, so with this kind of X-ray, you really do need to see a clinical picture, and if possible, a short video clip, 3-4 seconds, watching the child walk to see what the other extremity looks like. Is it normal? And then once you've answered that question, the other extremity is normal, then you know that you have a problem on the lateral side. If the problem is a recurrence of what they were trying to treat before, then chances are that there is a bar on the medial side. One of those chondrodysplasias we talked about comes to mind, and they will need probably an MRI scan of that distal femur to work out what the growth plate is doing on that side. I think you need to know that before you do your next surgery.
Yes, and then to maybe look at the whole of a child and see what the other limbs really look like. Okay, maybe we'll take a few questions quickly so as not to ignore those, and then we can get back to this if we have a few more minutes later on. So Dr. Ekunife Remigius says, we have seen cases with 180 degrees internal rotation and the foot facing completely backwards. I think that's a follow-up from his former comment, which says, remember that Browns presents with triplanar deformities, varus internal rotation, and procovatum, and most times the varus and internal rotation are the most prominent. Dr. Bakari says, how do you prevent knee stiffness in these patients? Well, if you don't mind, I'll just make a small comment about that. The fear for knee stiffness in children is not the same as the fear in adults, because a child will move, and once you get them out of casts, they just want to catch up with their friends and get on with life. They're not going to get very stiff. So you mobilize for as long as is required. But what are your thoughts about that as well?
If I may answer the question, thanks for your answer. I think there's just a little to add to it. Is in terms of the fact that I don't know how long people generally keep their patients in a cast. That's number one. And number two, if they use a frame, I don't know how free the knee joint is. But I think that if you're using a frame, then the knee joint, I would hope or imagine, is left completely free to move. And I don't think you'll get stiffness there. But with my own patients, with the knees, I don't seem to get any stiffness of significance, even in the adults, because the total time, because the internal fixation is quite secure. So I can cut down the total time in a cast to 8 to 12 weeks, really. And then once the cast is off, they can just start moving the knee and walking normally. With the children that we do the intra-articular osteotomy, usually by 8 to 12 weeks, the cast is largely off, so they can bend their knees. So again, it hasn't proven to be much of a problem. So it might be that it's just the length of time the leg is kept in the cast. That's number one. Number two, with the 180 degrees of internal rotation, foot facing almost completely backwards. Yeah, I've seen those as well. And usually I would actually derotate before I start putting all the wedges in. And if you derotate before you put all the wedges in, remember what I said about taking a little sliver of bone, and certainly in the tibia, to decompress things a bit. That often helps. So you do a complete derotation before you start taking or putting wedges in or anything like that. And I haven't found that to be a problem at all.
Okay, thank you very much. So Dr. Benedict Okechukwu via the YouTube channel says, how do you sort out the laxity of the lateral collateral ligament following corrective osteotomy in patients with severe Blount's disease?
Well, I know people have a lot of talking about this and everybody argues with everybody else, this, that, the other. I actually have a rather simple response to that. If your joint articular surface is not horizontal and you have not reconstituted the joint, well, you're going to have problems with ligament laxity, especially in the children. In the pediatric population, if you manage to restore the joint line and the knee joint properly, I haven't found that to be a problem. If your tibial articular surface is still sloped and if you do a valgus varus test, it still keep going in and out, then there's no point doing anything about the ligament, in my opinion. You've got to correct the joint first. If you correct the joint first and you've still got ligament laxity, then by all means, any number of techniques to repair that or tighten up the ligament is fine. I haven't had one done that I had to go back and do anything about the ligament. The only time I've had problem is if I have not reconstituted the joint. And every time I've got a horizontal joint line, I've had no ligament problem. So I think go back and get a horizontal joint line first. Then if you're still having problems, then by all means deal with the ligament. But the ligament will, you're not correcting the joint line is not going to be forgivable by tightening the ligament. It doesn't work. You've got to get your joint line sorted first, your joint reconstituted. And then you find out you can't actually do any valgus varus. Everything just tightens up.
Thank you very much. We have the very kind congratulations of Professor Lawipo on the YouTube platform as well. So thank you very much for your support, sir. I don't know if there are any other comments or questions from anyone. We have another 6 minutes and
yeah, Kemi, have you taken the comment from Dr. Okechukwu?
I can't seem to see it actually.
That's correct. I can't seem to see much of the comment as well.
Yes,
so
I can only see welcome everyone.
Okay, there's a comment. There's a comment from a question from Dr. Okechukwu. He wants to know how you sort out the laxity of the LC. Hello, can you hear me?
I have already. That was all we just finished discussing.
Okay.
From Dr. Benedict Okechukwu on YouTube. Yes, I have.
Yeah.
Yes, so I think we're done with all the questions, all the comments. I'll just say thank you, everybody, for your continued participation. Thank you for your questions, comments, your well wishes, your support. We still are constantly looking for people who are interested in volunteering to teach or to take up some of the huge administrative burden on Dr. Shobody's shoulders for this work as well. So you're all welcome to participate. It's our platform, it's our thing. And once again, we do see Nigeria setting the pace in that regard, in this regard of orthopedic education for residents and of having a platform that's useful for bringing subspecialists from different places together and getting us all to interact and be one big functional family. The only other thing to say is, in line with what Dr. Didapo said in his lecture, it would be nice for us to pool results and cases across different subspecialties, sort of have like a multi-center, thing for Blounds, and then see how much of a correction we require, because these are still questions we don't have answers to. Should you restore the joint line to, say, 5 degrees of valgus? Should you try and get to 10 degrees of valgus? At what age should you get to 5 or 10 degrees of valgus? And what would be, the eventual outcomes? These are questions nobody in the world can answer for us, because they rarely ever see Blounds. We see it all the time, and we have not just the patient volume, we have the burden of this particular disease, and it's everywhere. So I suppose we can pick this up on the Pediatric Orthopedic Forum via WhatsApp as well. Are there any other comments, or are you happy for me to close the meeting?
Just one more comment. I've just been leafing through the Dr. Ekunife. He's made one comment. He says the major problem in our locality is late presentation. That is correct. A lot of people have this belief that the bow leg will resolve as the child grows. So the patient presents very late with Lagerskoll grade 6. That is also correct. So the factors responsible for late presentation is multiple. One of it is education. It will correct. Actually, it's not just education, it's education and access to healthcare. Well, if everybody is telling you to correct, you don't want to go and see the doctor if you have to pay 2K every time you go to the general hospital. Or if you then see the doctor, they tell you that, oh, you need 50K. Even if, there's no hospital you're going to walk into in this country where where they're going to do this child for free. These treatments in these children, as far as I'm concerned, we as a group should be making representation to people in National Assembly, NHIS, whoever we know that children with deformities, these things should be done. Government should pay for it. It should be done for free. So yes, is community education, and 2 is access to healthcare. Because there's no amount of education you tell them to bring the child. If they don't have money to pay for, to visit you and to pay for your osteotomy, no matter how cheap it is and you're going to do even K-wire, you're still going to charge them 100K. We have to improve access to our children in this environment. So yes, I understand that, but we have to educate our communities, number one. Number two, we have to make care accessible. Because if they have to pay for it, they still will not bring the child until it's very, very, very bad. So that's my take on that, and that's what I found to be the case.
Thank you very much for that comment. I suppose on this not very happy note, we would have to close the meeting and see you everybody next week, Saturday again at the same time, and Sunday at the same time as well. So we're gradually rounding up our spine sessions and pediatric orthopedic sessions, and hopefully would have a bit of post-course assessments really and feedback for everyone who's participated. Thank you very much, and see you all next week. Bye.
Thank you. We're very grateful.